Hello, everyone. Welcome to another edition of Therapy Thursday. Today is the 3rd of March, 2022. This is Therapy Thursday brought to you by UNC Therapy Services here in North Carolina. And my name is Evan Adler. I am your host, creator, curator, sometimes presenter, but not today. I am the chair of our community engagement committee. And we do Therapy Thursday now about once a month as a way to reach out to the community and deliver something back in this difficult, uncomfortable time of COVID where we're not doing as many hands-on events. And we really want to get out there and kind of deliver the goods to everybody, really show you what physical therapy can do in a good educational perspective. So as we go through here today, we'll be using the chat function. So if you have questions, I encourage you to use the chat function and put your questions in there. I will be monitoring the chat, and if it's something urgent, we'll try to get it answered. But hopefully we're going to try and save all the questions to the end, but feel free to put the questions in there at any point and I'll keep track of it. I'm also going to put a couple of links in the chat for our Facebook page where you can find out about more events for UNC Therapy Services, and a link to our YouTube page where you will find archived talks of previous Therapy Thursdays. You'll find topics from anything from neck pain, knee pain, running injuries, dry needling, a slew of other topics. So I invite you to go ahead and take a look and thumb your way through that. There's some great information. Okay, so to the heart of the matter for today. Today we have a presentation from a special guest presenter. He is a second year Doctor of Physical Therapy student at Elon University. He's been doing his clinical rotation here with me in Northwest Cary for the past 8 weeks. He actually wraps it up tomorrow. We're sad to see him go. He's been fantastic. So today's topic on blood flow restriction therapy and training is going to be brought to you by Zachary Ormond. And Zach, I'm going to turn it over to you. You can go ahead and unmute yourself and share your PowerPoint, and we'll go from there.
All right, good deal. Can everybody see what's going on? All right, so thank you, Evan, for the intro. I'm Zach Ormond. I'm from Durham originally, and I go to Elon. And so today we're going to be talking about blood flow restriction training or therapy. Okay, so this is just the agenda. What is on the agenda today? So we have what is blood flow restriction training? Is it effective? What are its uses in the physical therapy realm? And then finally, is it right for you? Okay, so let's get started. Some history. Okay, so originally BFR started, let's see, in the 1970s in Japan. It started by a gentleman who had torn some ligaments in his knee, and he actually started to rehab himself using some blood pressure cuffs. And he kind of found that working at a low load, that this was something that kind of benefited him, and then he wanted to market it, and it became known as Katsu, and it started in Japan. And then in the US, it came shortly later, and the military started using it for limb salvage. And then finally, sports got a hold of it pretty quickly after that. And so now it's kind of been integrated into therapy, and actually the APTA, which is the governing body of physical therapy, it's the American Physical Therapy Association. They published an article on BFR, and they actually said BFR is part of the training, or is part of the professional scope of practice for physical therapists. And they went on to say further that PTs receive sufficient education on the body to be able to know and utilize this clinically. And so today, more therapists are using it more and more for different kind of outcomes, and we'll get into more of that today. All right, let's see. Next, okay, what is it? So, blood flow restriction therapy or training uses a device that restricts blood flow um, to the limb that it's applied to, kind of distal away from the limb that it's applied to. So the cuff that you apply around, and to the right I have a picture of a Delphi unit. This cuff restricts kind of the influx of blood, giving oxygen to that muscle that's away from the cuff. Okay, so the idea of this is that lower loads equal greater gains. So you have the cuff that's applied, it's applied, and then you kind of work out with low weights, and it's supposed to kind of be beneficial for the muscles and similar to high load training. All right, a little bit more info on it. So it's a short quote here from Pearson. It's hypothesized that ischemic and hypoxic muscular environment creates blah, blah, blah. Essentially what this says is that BFR provides the right conditions for the muscle to grow. And so it's been studied again and again. And basically, there's theories. You have the metabolite theory. There are a couple other theories that actually kind of go into why BFR is so kind of beneficial to the muscle and why low loads actually produce some good gains. Okay. All right, so what is it used for today? Here I have two pictures. We have two cuffs on the biceps, and then we have another Delphi unit on the leg, on the quad. And so I'll get into talking a little bit about Delphi and Owens. So these are two big names, Delphi and Owens, that have blood pressure cuffs, and they sell whole units with monitoring for pressure and everything like that. And so today it's used a lot in athletic training, therapy, it's used in sports. Tourniquet styles are still being used like in surgery today. The military still has use for this. All right, so is it effective? And then how do we measure its effectiveness? That's the first question we really want to ask. So how do we measure this? And so we'll measure it by our 1 rep max, and that is the most load you can lift one time. Okay, so let's imagine a bench. I put 245 on the bench, and I can only rep it one time. That's going to be my 1 rep max. We also look at the effectiveness of BFR through the muscle size and how much muscle size changes over time using this. We're going to look at torque, and kind of that's peak force and power that the muscle is able to provide using kind of the muscle's energy. And then we have our arterial occlusion pressure, and that's actually how much the cuff restricts the blood flow or restricts blood getting to the distal extremity. All right, these are just some recommendations. And over to the right, I have someone calibrating a blood pressure, a BFR cuff. And so our occlusion rate, and that's something that I kind of touched on before, so rate is going to typically occluding the artery supplying blood 80%. So that means 20% of that oxygenated blood is getting through. Okay, so the ACSM, the American College of Sports Medicine, recommends that lifting at least, and this is regular training, this is no BFR, lifting at least a load of 70% of the 1 rep max just builds normal muscle. And so that's typically what we do in the gym. You know, I'm lifting, and say my max is 245 and I'm lifting 200 for reps. That would be 70% And then you get down to the actual recommendations for our BFR, and you're only working at 20% of the 1 rep max, and this could end up being like 90 repetitions to be a set. And so that would be just 20%. And so this is only the amount you would want to work at using BFR. It's just the 20% of the 1 rep max. And that is enough to provide sufficient gains, and gains equal to 70%. And so that's kind of a big dichotomy right there, 70% and 20%. But the theory is that yes, and the science says yes, that 70% can be that 20% with BFR. Okay. All right, so limiting factors, and over here we have Dr. No. So these are don't do's. So we'll just talk about the medical contraindications first. So typically, this is going to be contraindicated for anyone with blood clotting disorders, history of hypertension, history of DVTs, pulmonary embolisms, and strokes. You're also going to be limited to where you can place the cuff. You know, you're not going to be able to place it around someone's neck to work the pecs. That's not how it works. It only works kind of distally to that muscle. So if I put it around the upper arm, I'm working the bicep, and you can't, yeah, you can't work proximal muscles. You can't work muscles that are closer to the body, and that's going to be kind of one of the real limits of this, but it's still super useful. And then finally, duration. It's recommended that it's used for less than 20 minutes. So 20 minutes has been studied to be safe for this. So 20 minutes is safe, but 5 minutes is recommended. And 5 minutes is what they kind of calculate for how long it might take a set to be done. So at the end of the last set is ideally when you'd want to kind of take off the cuff and give that extremity some blood flow again. All right, so let's apply this clinically. There have been, at this point, probably hundreds or maybe thousands of studies done on BFR, looking at atrophy, sarcopenia, which is muscle weakening, and then you have osteoarthritis. And so in a study on quad strength and OA, quad strength has been heavily connected to the beginning of knee OA. So if you have decreased quad strength, again, you're going to have a potential for OA as you get older. And so the BFR actually has been proven to increase the quad strength. And then we're going to look at Achilles tendon rupture rehab. So again, this is a study done by Centner, and Centner has been a big name in BFR research, especially for physical therapists. And Centner has kind of looked at where to use it and on what conditions and everything like that. Centner used this for Achilles tendon rupture rehab, and using BFR actually was able to improve muscular strength. Not only that, but it improved the stiffness of the tendon of the calf muscle that the Achilles attaches to. So this is beneficial. Okay, next slide. More clinical applications. You might see this being used a lot for like ACL rehab, and so it's been found that this can also be helpful for ACL rehab. It's not going to improve the actual ligament, the ACL, but what it is going to do is help build the muscle, the quad. It's going to help build that quad strength up and kind of protect the ligament itself, the joint itself, by being a stronger muscle and being able to stabilize better. So it's been proven to do that. Increase of size by 11% and strength by 20% in the first 4 weeks. And then we have detraining. So in the cases of detraining, it's had similar results looking at the quad with an increase of total size, total tonnage to also 11%. And another thing about this study was that it showed that after 4 weeks of like a cessation of exercise, so they haven't exercised for 4 weeks, this still shows that increase of gains are maintained similar to high load training. All right, one of the more interesting studies, again, another study by Sentner. You have your low load BFR, and they worked at 25%, um, and they worked at that 20 to 35% range of our low load 1 rep max, and that increased patellar tendon stiffness and strength of the actual quad. So the tendon was able to get stronger, similar to how the tendon got stronger in the Achilles tendon rupture. The muscle mass increased, similar to high load training. So that's 70% of the 1 rep max. And then it showed its biggest benefit in actually improving a person's 1 rep max after the use of BFR had ended. Okay. All right, so more clinical applications. This is safe to use. It's been studied to be safe to use with older adults. It helps, again, with hypertrophy, building muscle. There are going to be slightly lower strength gains, but the building muscle part to protect joints, it does have effectiveness there. Another study by Sentner. All right, so now BFR for regular exercise and some of its protocols. So I think the ACSM put out that BFR is safe to use until the last set. And so it's predicted that a set might take someone 5 minutes. And so you're going to do 4 sets, 30 seconds in between your sets. You're working at 20 to 30% of the 1 rep max, something we talked about before. And we have a GIF over here, GIF or GIF, of an up phase lasting 1 second and a down phase 1 second. And then we're working at our 80% arterial occlusion. So the artery with the blood flow is getting restricted 80%. And so Delphi and Owens, so we have a graph or a chart from Owens Recovery. They sell kind of more expensive BFR sets that actually read out the arterial occlusion pressure so you can monitor it more safely. And so now when we get into what cuffs to wear with BFR, there's a lot of science out there about what's safe and what's not safe, and at what pressure should you use the cuffs. And so it's kind of thought now that a wider cuff is going to be more beneficial for one, occluding the artery, which is something that we want, and then two, it's going to be it's going to have that wider surface area, which is going to be safer for our nerves and arteries in general. One of those narrow elastic cuffs that can be have more detrimental effects to the nerves and arteries if you keep it on for a long time, because it's more localized, keeping that large amount of pressure in one spot. And so wide cuffs are going to be better. All right, so finally, kind of wrapping it up, is BFR right for you? So studies have shown in rehab, the initial stages of rehab, BFR is extremely good. It works really well, but it's still very useful to use high load exercises without BFR, because these improve like our structural components, strengthening the bones more, and that's when we get into exercise as well. So BFR maybe isn't the best use of exercise because we still want high load training in there sometimes. And then getting into bodybuilding, you have your pump effect that BFR is known to give. So you get kind of pumped up with BFR, And so in bodybuilding, it's something that's definitely being used more and more, but um, there's more studies that need to be done on BFR in bodybuilding. And finally, I have my resources, um, my sources, and so those are all here. And now, any questions?
All right, Zach, thank you very much. That was really, really informative. This is it's a developing field right now. I wouldn't say it's in its infancy, maybe more towards its toddlerhood, um, but it certainly there's more research coming out on it. Um, as we're here right now. I should put a little caveat in here to say that here at UNC Therapy Services, we are just starting to get into the use of BFR and starting to get units in house to start using this technology. So we'll be able to see more of a firsthand case studies of what to expect with these. Now, with that said, there were a couple of questions that came up in the chat here that Zach, I'm going to throw to you, and we'll see if we can address some of these together here. So the first one is a question that I actually posed earlier, saying that you said that there's some studies that have been done that this can be beneficial for the use surrounding osteoarthritis, particularly at the knees. Now, when I see this BFR, in my mind, the first thing I think of is a young, relatively healthy person in the gym trying to build bulk and hypertrophy the muscle. So, is this just a young person's adjunct treatment, or is it to be used for those with OA in the more age advanced population?
Right.
What do you think?
Yeah, so I've done a lot of the research, so a lot of you won't have to. So yes, it's been proven to be beneficial for older adults. You get more gains in strength and also just that hypertrophy also. We see the same effects in older adults as well as young individuals.
That's great. So it's okay for your older individuals to go and get swole out there.
Yep, guess well.
Good, good. All right, so there were a couple of questions here, a couple of interesting questions. Now, one of our attendees wanted to know if you've read anything about the possible connection between BFR and increased risk of rhabdomyolysis.
That is an interesting question.
So if you're, for those of you watching that may not be familiar, rhabdomyolysis, it's a fairly serious condition where the muscle tissue um, basically breaks down and releases proteins and all sorts of stuff into the blood, can damage kidneys, can have some serious heart effects as well. Um, so have you noticed anything, read anything about a connection between these?
Right. So there were no studies that I read, and a lot of the contraindications, um, and kind of the more medical contraindications, yeah, they never stated anything directly about rhabdomyolysis or rhabdo, but we know that some individuals are more prone to getting rhabdomyolysis, and I'm kind of from what I've seen, I'm not sure that BFR would impact like the rate of people getting rhabdomyolysis.
Okay.
So
Yeah. I have not read anything to that effect either. Um, I don't know what studies have been done. I would have to think that there are just inherent risks when we start to occlude blood flow, and we're also putting a lot of pressure on the tissue. So I think making sure that we follow appropriate guidelines that have been set forth by Owens and by blanking on the other company name right now. What was the other one?
Delphi.
Delphi, thank you. Um, I know that those companies have done due diligence to set up protocols for the usage. So, um, that's the best information that personally I would go on at this point. There was one other question in the chat that was, if you're using BFR on a post-op knee, what effect, if any, would you expect the BFR to have on swelling in that region?
Yeah, so that's another good question. So, um, you might actually think it would reduce swelling in the region because you're getting more of a muscle pump. And after the BFR is taken off, you're gonna have a lot of blood that's gonna kind of leave from that area after that kind of pump has happened. So
Yeah. Yeah, I think, we often, we recommend to our patients, compression for decreasing swelling. So I would have to think that it does have hopefully a beneficial effect on the region. But again, should be something to be monitored, particularly for any distal extremity, distal to where that swelling is. So if we're using it on your thigh for your quadriceps to build that up, it should be in the clinician's best interest to really monitor the calf and the foot, making sure that there are no negative fluctuations in those regions. So I would agree. I would expect to have hopefully a beneficial effect in that region, but really needing to monitor distally to making sure that the pump is bringing that venous return back to the heart to process. Okay, so are there any other questions from the field? We have a few people on here. Any questions? You can drop them in the chat. While we're waiting for any more questions, I'm going to go ahead. I'm going to put those links back in the chat again of our YouTube page and our Facebook page. I encourage you to please go ahead, subscribe and like and do all the clicking and things to give us some digital love. So we're gonna hold it open for questions for let's give it another 30 seconds or so. While we do that, just go ahead and publicly give a thank you to Zach for his presentation today. I know it's not easy doing an in-service like this, especially as a student. So good job, very, very good job today. And he'll be going back into the classroom real soon. So you've got lots of good learning ahead of you and a good long career too. So good job. Any other questions from anybody? Going once, going twice. Okay. Well, thank you everybody for attending today. This has been another episode of Therapy Thursday brought to you by UNC Therapy Services. Thank you all for joining us. Please visit our YouTube page for previous installments and Facebook to find out about future events. All right. Thanks all. Have a good one.